slides?
Yes,
Yeah,
yes.
we can see.
Yeah. So thank you so much, sir. First of all, I would like to thank Rajesh sir and Mohit sir to inviting me to take this session, and of course all the organizing committee of Neocon 2024. So without wasting time, let's see. Before I jump into the our main focus, I would like to just show the two picture. This is your pre-test. No need to answer right now. We'll discuss at end of the session. So first of all, anyone when you do the ultrasound, we have to see that does it normal or abnormal. So in front of you, there is a two picture over here. One would be normal and one would be abnormal. If you find if it is abnormal, then definitely we need to see what is the abnormality. So in this session, I will try to cover the normal as well as abnormal condition by the Hale ultrasound. Okay. So before I jump into the all the views and grade 1, grade 4 IVH, I would like to discuss one the ventricular anatomy, because it is very important thing to know that to fit the 3D structure in your mind. So if you know the anatomy, definitely it is easy for you to diagnose all kind of IVH and all kind of hydrocephalus. So Dr. Kunal yesterday very well covered the sonography and anatomical view. So basically most of time we are using the anterior frontal view to get all the coronal as well as sagittal view. But sometimes we have to use a supplement view like posterior master view to rule out, like for example, for cerebellar hemorrhage, we have to do the master view. For the grade 2 IVH, sometimes the echogenicity is shifted into the occipital region, so rule out does it artifact or does it part of the IVH. We have to do the posterior view. Linear transverse people are used because sometimes there would be extra axial fluid, or sometimes there would be subadequate hemorrhage, which is very well seen in the linear probe. Of course, the Doppler is very important part of the hydrocephalus to see the intracranial pressure, and for that we can use the anterior cerebral artery and middle cerebral artery. So this is your 3D view over here. You can see this is your lateral ventricle, and this is the third and fourth ventricle. If I put the picture one by one, this is your third ventricle. This is your foramen Munro, which is connected to the lateral ventricle, and this is your aqueduct, and this is your fourth ventricle. This is the side view of the third and fourth ventricle. And this is your front view, means from the face. So this is your third ventricle, this is your aqueduct, and this is your fourth ventricle. The important point to be remembered when you do the sagittal view, then you can't see the lateral ventricle because it is in a lateral part. Okay, so that has to be remembered. So this is your third ventricle, this is your aqueduct, and this is your front ventricle. Now, when I add the third lateral ventricle in this structure, you can see this is your crescent shape lateral ventricle. This is your, again, this is a side view. Okay, when you see from front, now you can see that how does it look from the front. Okay, so it is connected with the third ventricle by the foramen Munro. If I if you see the part of the lateral ventricle, this is your frontal horn of the lateral ventricle, which is covered by the frontal lobe, and it is connected with the lateral ventricle with the foramen Munro. This is your body of the lateral ventricle. This is your posterior horn of the lateral ventricle, which is covered by parieto-occipital lobe. This is your inferior horn of the lateral ventricle, which is covered by the temporal lobe. Okay, clear till now? So when you do the sagittal lateral view, you are putting your probe over here. Am I right? And swipe to either right or left side. So when you swipe, like suppose in the right side, you are cutting the lateral ventricle like this. So that's why you can see the crescent shape in your echo machine. Okay. When you do the coronal view, you put the probe on the right side, or the marker, and you are cutting the frontal horn over here. You can see the lateral ventricle, and you can see the third ventricle, which is connected by foramen Munro. Okay. Now next slide is very important to know about the IVH and everything. So I now add the basal ganglia and the cerebellum. So this is of course the cerebellum. You can see the brown color structure over here. It's supposed to be posterior to your fourth ventricle. So front part is covered by the brainstem. Okay. and this is your, when I add the basal ganglia. So now if I talk about the part of the basal ganglia, this is your caudate nucleus and this is your thalamus. So adjacent to the caudate nucleus, there would be the frontal horn of the lateral ventricle, and between that there would be germinal matrix. Okay. When you go to the thalamus, the adjacent part is the posterior horn of the lateral ventricle, and between that there would be the choroid plexus. Okay, that is important point to be remembered. So this is your caudate nucleus and this is your thalamus. If you see from front, from the front side, you can see this is your caudate nucleus and this is your anterior horn of the lateral ventricle. Now I add both lateral ventricle over here. If you see, okay, so this is both our frontal horn. So anyone from the delegates, can you say what would be in between that one? Anyone? You can put on the chat box. Okay, so this is your septum pellucidum. So in preterm baby, it might be filled with the fluid, and that's why we call it as a cavum septum pellucidum. And just above that one, there would be your corpus callosum. Clear? So this is your brain stem. So in front of your fourth ventricle, there would be the brain stem, and posteriorly there would be cerebellum. This is your septum pellucidum. Now I add the cerebrum. Okay, cerebral hemisphere. You can see this 3D view over here. Okay, so if I talk about the structure, this is your cerebrum. Anyone know that what is in this green color thing from the delegates? Anyone from the audience? The green color structure is your corpus callosum, okay, which is connected to both hemisphere. Correct. Now, if we go further, there would be the lateral ventricle over here. In between the lateral ventricle, there would be your septum pellucidum, okay. And later to your lateral ventricle, there would be your caudate nucleus over here. The slide is stuck, sorry. Okay, yeah. So this is your caudate nucleus, this is your thalamus, this is your brain stem, and this is your cerebellum. So now you can know that what you are going to see when you do the sagittal view, when you do the coronal view. Still, I would like to discuss the few of important view. This is your foramen Munro and foramen mid-ventricular coronal view, and most of people are confused with these two picture because it looks like same. We see the in 3D and we can understand the anatomy, but when you see the real image, it is difficult to appreciate that which one is a foramen Munro and which one is a mid-ventricular. So this is your foramen Munro. How can you differentiate? You can see over there is a echogenicity over here. So this is your tip of the choroid plexus. Okay. Once the thalamus is start adjacent to the lateral ventricle, there would be your echogenic foci is over there. That is your tip of the choroid plexus. But in foramen Munro view, there would be no any choroid plexus over here. Okay. So if you find the echogenicity, that might be the grade 1 IBS. Okay. Second important point is you can see there is an inferior horn of the lateral. You can see very good circle in size. Like in the foramen Munro, you can see the that much big size of the your inferior horn of the lateral ventricle. Other things like if you see over here, there is a brainstem over here. Here is it would be the cerebellum, or you may see the vermis in between that one. So, but it is difficult to appreciate and difficult to it would be subjective finding. So, two main point to be remember in mid ventricular view, you can see the echogenicity over here, okay, and the round size of the inferior horn of the lateral ventricle. Okay, this is also important point, important view, mid sagittal view. So your probe should be facing the nose over here, and when you cut the size, you can see over there is a corpus callosum. It is not a lateral ventricle. Okay, it does looks like a ventricle because in the preterm the septum pellucidum is filled up with the fluid. So this is your cavum septum pellucidum. This is your foramen munro, which connect to the your third ventricle. Okay, this is your cerebellum. This is your fourth ventricle, and in front of there would be brainstem. Okay, what is this? This is your anterior cerebral artery over here. Okay, so once it arises from the carotid artery, it travels slightly medially and it goes superiorly in front of the genu of the corpus callosum. We'll discuss this thing at last when we discuss the RM. So this is your mid sagittal view. This is your sagittal lateral view. We call as a parasagittal view. That is also fine. So when you swipe the probe towards the right or left side, you are cutting the lateral ventricle, and you can see whole crescent shape your lateral ventricle. Now, if you see the real image, this is your thalamus. Okay, this is your choroid plexus over here, and it stopped going further over here. That is your chordothalamic notch. Okay, this is the most common site for the IVH. Over here there would be your corpus callosum, and there would be the germinal matrix near to adjacent to that part, and which is more prone to the bleed. Okay, so this is your lateral ventricular view. Now let's go to discuss the main topic, the intraventricular hemorrhage. Why it is common in the preterm? This is the most common neurological complication in the preterm because there is a germinal matrix, and the germinal matrix is your fetal tissue. It is not a mature tissue. Okay, once baby is crossed like the third trimester, more than 34-35 weeks, it is going to be goes away. Okay, why is it important structure? Because it is a precursor of the lots of neurological cell and is helpful for the neurodevelopment outcome. Why is it fragile? Because there will be lacking of the supporting basement membrane, where is tissue, more fibrinolytic activity. There would be no that much strong auto-regulation. So there is a long list why there is IVH. Okay, there's a few points which should be remembered, like what are the risk factors. The less than 32 weeks and less than 1.5 kg babies are more prone for the IVH. There would be, if there is a rapid changes of blood pressure or blood volume or any ischemic event leads to the bleed. RDS itself not going to do the IVH, but because of the ventilation, improper ventilation, you might have a baby might have a hyper or hypocarbia. This leads to the bleed. Coagulopathy because of the sepsis or any other reason. Transfer from the periphery, like 600 grammer, when you transfer on the periphery, we need a gentle handling. These are all risk factor for the IVH. So how to identify? Okay, I'm not talking about the grading right now. This is just initial image. So if you see the coronal view over here, this is your which view? Anyone from the delegates? Which view this one? I just waiting for your answer, at least from one. Tissue view. Okay, that's right. So this is your foramen minimum. Why is it so? Because there, you can see there would be the your foramen minimum over here, and over here there is a third ventricle. This is your lateral ventricle. Okay, and this is your caudate nucleus. If we see the real image again over here, this is your interhemispheric fissure. This is your lateral ventricle, and this is echogenicity. You can see over here. Okay, if it is choroid plexus, you can see both echogenicity on both sides. But here there is a unilateral over here. So that might be chances of the IVH. Which grading we'll discuss further. So this is the echogenic thing you can see at lateral border of the lateral ventricle. Okay. So this it do when there is a flare split, it would be the echogenic, and once it start resolving, you will see the echolucency in within it, and it might resolve. If you do the sagittal view, this is your parasagittal view actually, and we know the view. So this is your lateral ventricle, crescent, so you can see whole, the inferior horn, posterior horn, body and frontal horn, and this is your thalamus over here. Okay, and this is your choroid plexus, and choroid plexus has the same echogenicity like a blood. So that's why we always confuse that, does it part of the choroid plexus or does it part of the IVH? Am I right? So once you see that it crossed the chordothalamic groove over here, that means you are dealing with the IVH. So in sagittal view, parasagittal view, you can see inferior border of the lateral ventricle, and mostly it probably anterior to the chordothalamic notch. So now classification. So there are mainly two classification, and world over that is accepted in many research, and most of 99% of the people are practicing based on this classification. One is papile classification, or we call papile classification, and Volpe classification. So papile classification is based on the CT scan, and Volpe classification is based on your ultrasound. Okay, so if I talk about the grade 1 IVH, when your IVH or bleeding is stay in the germinal matrix, no leak of the blood into the in the lateral ventricle, that is your grade 1 IVH. When there is a bleeding into the lateral ventricle, but blood amount is not that much enough that can cause the ventricular dilatation, that is your grade 2 IVH. When there is a IVH in the ventricle, but it is sufficient amount can dilate the lateral ventricle, that is your grade 3. Remember my friend, the dilatation must be by the blood, not by the CSF. That is important point to be remembered. And when there is a bleeding, not only in the IVA, in the interventricle, but in the parenchyma, that is your grade 4 IVH. If I talk about the Volpe classification, which is based on the ultrasound, in grade 1, your IVH is remain in the germinal matrix or with or without less than 10% of the ventricular area. If it is more than 50% of ventricular area bleeding in the lateral ventricle, that is your grade 2 IVH. And if it is more than 50%, if baby has a more than 50% bleed in their lateral ventricle, of course they are going to dilate. So ventricular distension you can see if it is more amount, that is your grade 3 IVH. And when the IVH associate with the parenchymal hemorrhage, that is your grade 4 IVH. So let's discuss one by one. How does it look? So this is your coronal view or coronal section of the preterm brain. You can see over here there's a less sulci, less gyri, so this is extreme preterm baby, and over here you can see there's a lateral ventricle, and near to there, adjacent to that structure, there is a germinal matrix hemorrhage over here. You can really see that it is not leaking into the lateral ventricle. So that is your grade 1 IVH. Then how does look on the image? So again, this is your foramen Munro view, and this is your lateral ventricle. This is your cavum septum pellucidum. This is your third ventricle, and here is your echogenicity. You can see over here. It does look like a grade 1 IVH because it is not leaked into the lateral ventricle. Still, it is a subjective finding. Sometimes people say there is a coronary plexus or something else. How will you rule out that one? So for that, we need to do parasagittal view. Okay, so we know that one. This is your lateral ventricle over here. This is your coronary plexus. This is your chordothalamic groove, and this is your grade 1 IVH. Okay, so this is your caudate nucleus. This is your thalamus. So there would be no leak in the lateral ventricle. That is the main point in the grade 1 IVH. Of course, there would be the misinterpretation. We already discussed in the previous view that this is your mid ventricular view. You can see over here there is a echogenicity over here. Okay, it does look like a grade 1, but this is might be the tip of the your coronary plexus, and over here, as we see in the previous slide, that is your grade 1 IVH. Okay, so for rule out does it normal or abnormal, we have to do the parasagittal view. And in this image you can see the echogenicity is not crossing your CTG, chordothalamic groove. That means this is a part of the coronary plexus, not a part of the IVH. And in this image it is crossing the echogenicity, it is crossing the CTG over here, and this is your grade 1 IVH. Clear till now? Now, what will happen if we, monitor this grade 1 IVH? Most of time, it is less likely to have a ventricular dilatation, which would be less than 3%. Initially echogenic, followed by equiluscent within it, and it resolve within a 2-3 weeks. So if I summarize the grade 1, in coronary view, you can see in foramen Munro view and mid ventricular view, echo density in the lateral border of the lateral ventricle. mostly remain in the germinal matrix. In parasagittal view, it is limited to the subependymal region, anterior to the caudothalamic notch, no leak of the blood in the lateral ventricle. And as we discussed, misinterpretation would be the grade 1 IVH versus anterior tube of the choroid plexus in the coronal view. For that, we need to do the parasagittal view to see that it is crossing the caudothalamic groove or not. Now, what about the grade 2 IVH? So this is your anatomical coronal section of the preterm brain. Again, this is your lateral ventricle, this is your germinal matrix, and it leaks the blood over here. Am I right? How does it look in the real image? You can see over here again, this is your foramen Munro view, sorry, mid ventricular view. Okay, now you can see over here there is a ecogensity in both sides slightly over here also. This is a tip of your choroid plexus. But if your bleed is more than germinal matrix, if blood is leak out into the lateral ventricle, you can see this echogenicity cover the more than 10% area of your lateral ventricle and less than 50%. Okay, so this is your grade 2 IVH. If I talk about the parasagittal, you can see over here, this is also like leaking into the lateral ventricle, and this is your choroid plexus. Look at the density, both looks like a same. Okay, so this is your grade 2 IVH, blood clot within the lateral ventricle adjacent to the germinal matrix without any dilatation. Still, there would be the few confusion in the grade 2. We'll discuss further. When there is a bleed in the lateral ventricle, we know that blood is more heavier than the CSF. So most of the time, because of the gravitational force, it goes into the posterior horn of the lateral ventricle. You can see this is the your coronal posterior horn view. Okay, and here there is a choroid plexus over here, and you can see this echogenic foci over here. That would be the part of the grade 2 IVH. Okay, when you see the parasagittal view, it is an ideal view to grade the grade 2, because of the gravitational force, the blood is goes towards the choroid plexus. Sometimes ecodensity is merged with your choroid plexus over here. Okay, so when you see the parasagittal view, when your surface is smooth, like choroid plexus surface is smooth, you can differentiate the does it blood or does it choroid plexus. There is a equilucent line over here. Okay, so base view would be the parasagittal view to grade the grade 2 IVH. Over here, still sometimes it is would be subjective finding, that some people can say that is a grade 1, some people can say there is a no bleed. But if your choroid plexus surface is smooth, you can see this equilution line between blood and your choroid plexus. This is your choroid plexus, and this is your blood. So that means this is a part of the grade 2 IVH. But what if your choroid plexus surface is irregular? Like if you see this image, there is an irregular surface over here. Irregular surface is over here. Then how would you know that does it part of the IVH or something else? So when you see the any ecogensity in other part of the lateral ventricle, that means that is a part of the IVH. Okay, but if you could not see any echogenic seeing or any bleeding around other place, that means it is a part of the choroid plexus, not part of the IVH. And this structure we call as a bulky choroid plexus. In case of the axiom preterm, sometimes less than 30 it is a common finding, and people might misconcept as a IVH, but it is not. Okay, so if you see the irregular choroid plexus with the germinal matrix hemorrhage, confused, look for the IVH in other part of the lateral ventricle. If it is there, that means it is a part of the IVH. If it is not there, that is your bulky choroid plexus. Okay, sometime what happen, that clot might separate from your main clot. Over here you can see this is a clot, this is your choroid plexus, and it's separated from the main bleed, and it settle in the posterior or occipital horn of the lateral ventricle. Again, does it part of the IVH or does it artifact? Because sometimes occipital region of the lateral ventricle, we can see lots of artifact, bright artifact, we confuse as a bleed. Again, same thing we need to see if it is associated with the bleeding in other part of the lateral ventricle, that is a part of the IVH, which we call isolated echogenicity. Like in this one, you can see still some echogenicity over here, but it is not associated with the bleeding. So there is no any value of that echogenicity, and that might be your artifact. Okay, so after when if we monitor this grade 2 IVH, the 7% of the baby might end up with the ventricular dilatation, and minimal amount of the baby require the therapeutic intervention. We discuss in the hydrocephalus. So after 2 weeks, this baby has a ventricular dilatation. You can see this is your foramen Munro view. This is your lateral ventricle. Over here, you can see the foramen Munro. This is your third ventricle. This is your inferior horn of the lateral ventricle. Okay, this is your parasagittal. You can see the old IVH, which is resolving. This is your choroid plexus, and this fluid. You can see this is a dilated lateral ventricle. If I summarize the thing, grade 2, the in coronal foramen Munro and mid ventricle, either of that one, you can see the echo density and bleed into the ventricle without any dilatation. You can also see the clots in the posterior horn view because of the gravitational force. You can see the clot in the parasagittal view, which is ideal view to grade the grade 2 IVH, and clot extend in the lateral ventricle without ventricular dilatation. And we already discussed the misinterpretation and pitfall there because of the choroid plexus, because it has a same echo density like choroid plexus. So if you see the smooth surface, you can differentiate with the equilation line between the your choroid plexus and the blade. If your choroid plexus surface is irregular, look for the IVH in other part of the lateral ventricle. If it is there, that means it is a grade 2 IVH. If it is not there, then it is a part of the choroid plexus. Sometimes we call bulky choroid plexus. If you see the isolated echogenicity in the occipital horn of the lateral ventricle, again you need to look for the IVH in other part of the lateral ventricle. If it is there, that means it is a part of the grade 2 IVH. Clear till now? So now let's see the grade 3 IVH. What happened in that one? So when there is a sufficient amount of blood into the lateral ventricle, it can cause the ventricular dilatation over here. Okay, so you can compare with the other lateral ventricle. It is a dilated. This is a not normal size. Okay, you can see also bleeding going in the third ventricle also through the foramen Munro. That is your grade 3 IVS. Then how does look on the image again? So this is your foramen Munro view, and this is your echogenic foci or echogenic clot over here in the lateral ventricle, and it also leaks into your foramen Munro. It covers the more than 50% of area. That is your grade 3 IVH. In the sagittal, you can really see that is a dilatation over here, and this is not a old IVH. Point to be remember, this is not old IVH, but blood is sufficient amount that can cause the ventricular dilatation over here. That is your grade 3 IVH. And remember, the most important point, it must be because of the blood. Dilatation must be because of the blood, not with the CSF. Okay, so large clot not only in the lateral ventricle but also in the third ventricle. In the parasagittal view, clot is big enough that can modulate it to shape of the ventricle. Common misclassification between grade 2 and grade 3. Why is it so? Because the original article does not decide the cutoff, which one is a grade 2 or grade 3. Second important point, they haven't mentioned that dilatation is because of the blood or CSF. But when we go into the detail of the articles, they show that CT scan shows the blood. So that we presume that dilatation must be because of the blood. This is the commonest mistake, not mistake, but commonest finding of the radiologist. For example, like in our unit, sometimes the baby has a normal head ultrasound at day 4. And after that, we ask for the ultrasound after 2 weeks. Okay. So when radiologists come and see that does it a ventricular dilatation or not, they mention there is a ventricular dilatation and that is your grade 3. But we haven't know the dilatation is because of the CSF or because of the blood. Okay, if you see this image, this is a ventricular dilatation already there, but we haven't know that it is because of the grade 2 or grade 3, and this is your resolving IVH. So if you could not see the that much amount of the blood, you can't label as a grade 3. That this one is your resolving IVH with ventricular dilatation. We can't grade this one. Okay, it might be grade 2 also, grade 3 also. So when you see the blood echogenic thing more than 50% of the area of the lateral ventricle with the dilatation, that is your grade 3. Okay. So if I summarize coronal view, of course, in foramen Mundro or either of wind ventricular view, you can see the blood is dilated the lateral ventricle. Parasital view clot has modulated to shape of the ventricle, and most commonest interpretation between grade 2 and grade 3 because of the we haven't known does it because of the blood or does it because of the CSF. It is with the blood, that means you are dealing with the grade 3 IVS. If it is with the CSF, we haven't know that is a grade 2 or grade 3, but it is a definitely post hemorrhagic ventricular dilatation. Now let's talk about the grade 4 IVH. So you can see in this anatomical coronal section that there is a bleeding in the both side, but over here it leaks into the paraventricular area in the parenchyma. So any IVH, any grade of IVH with the infarction or echogenicity outside of your lateral ventricle, that is your grade 4 IVH. So how does look? This is your again the mid ventricular view over here. This is bleeding in the both side. You can see the blood, same echogenicity is outside of your lateral ventricle. It is this is your parietal lobe over here. So this is your grade 4 IVH. Then how does look in the parasital view? You can see this is the whole ventricle is fill up with your blood, and you can't differentiate where is the blood. Cut there is a your lateral ventricle border. So there is a lots of echogenicity even outside of your lateral ventricle. That is your grade 4 IVS. Okay. So there would be the mechanism for that one. Like for example, this is your foramen Munro view. When there is a grade 1 IVH happen, that small IVH even is suffice to obstruct your venous return. This is your venous return over here, just adjacent to the germinal matrix, mostly vein of the Galen, and because that obstruction of the venous return, it end up with your hemorrhage over here. So it is not necessary that the grade 1 is follow grade 2 follow grade 4 and follow by grade 4 means 1, 2, 3. Sometimes even grade 1 IVH suffice to create the grade 4 IVH. It is not necessary it follow the sequence. You can see in this video, this is your foramen Munro view. Now there would be the grade 1 IVH germinal matrix 1. It obstruct the venous return and ultimately end up with your grade 4 IVH. Okay. Sometimes, like in the extreme preterm baby, you might see there would be the periventricular flare over here. There is no any bleeding over here. Okay, you can't see the bleeding, but there would be a periventricular flare. When we see this echogenic thing outside of the ventricle, we always worry: does it normal? Does it a part of the IVH? Does it end up with the PVL? We haven't known. So serial of monitoring is required. And when we do the scan next day, you can see there would be the grade 4 IVH because there would be a venous congestion over here and end up with the grade 4 IVH. So I am always worried about the periventricular flare. It is easy to label the periventricular flare, but we have to do a serial scan when you put the point in your notes. The same thing over here in the parasagittal, you can see there is a echogenicity over here. Periventricular flare is over here, like coronal plexus. Okay, and same thing happen after a few days. There would be the grade 4 IVH over here. So that's why it is important to know your periventricular area, specifically in the small preterm babies. This is another example. This is your grade 4 IVH. This is your mid ventricular view, your big enough blood which leak out into the adjacent area of the caudate nucleus and the thalamus, and over here you can see dilated ventricle with the bleed, also periventricular flare over here. So this is your grade 4 IVH. Okay, what happened in the grade 4 IVH next? So when there is a bleeding in the parenchyma, of course it is going to be resolved, but it creates the cystic changes in the periventricular area, and sometimes it merges with your lateral ventricle. We call that as a porencephaly cyst. Okay, over here that is your porencephaly which communicate with your lateral ventricle. It is difficult when there is a porencephaly to assess the hydrocephalus indicis. We'll discuss further in the after few slides. So till now what we discussed, all the four grade of the IVH. In the coronal view, you can see over here that is your echogenicity remain outside of the lateral ventricle only in the subependymal region. That is your grade 1 IVH. Again, that is if bleed is leak into the lateral ventricle but less than 50% of the bleed, not such amount of the blood that can cause dilatation. That is your grade 2 IVH. If it is dilated the ventricle, that is your grade 3 IVH, and dilatation must be by the blood, not by the fluid. And last one is your grade 4, which one leaks into the outside of the lateral ventricle, that is your grade 4. And as I told, it is not necessary to follow the grade 1, 2, and 3 and 4. It must follow. It is not must that follow 1, 2, 3, 4. Sometimes it convert from grade 1 to grade 4 also. If I talk about the parasagittal view, you can see this is your choroid plexus, this is your CTG, and it is crossing over here. This is crossing the caudothalamic groove. That is your grade 1 IVH. No bleed in the lateral ventricle. Because of the gravitational force, once it leaks, it goes into the posterior part or posterior half of the lateral ventricle. That is your grade 2 IVH without ventricular dilatation. If there is a bleed more, then it creates the ventricular dilatation. That is your grade 3 IVH, and this is your grade 4 when there is a fill up of the blood, or sometimes even grade 1 is also create the grade 4, and periventricular brightness is there. That is your grade 4 IVH. Clear till now? Any confusion? Should I go ahead? Okay. So now what next? Uh, my slide is stuck again. Sorry for that. Okay. So what next? So what happened if there is a bleeding, either grade 1 or grade 4? So there would be always worry about the ventricular dilatation. Why is it so? Because the bleed inside the brain, and it is a sticky structure. Once it's resolved, it releases lots of inflammatory marker. There would be the chronic inflammation, and it block the pores of the absorption, and it create the ventricular dilatation. Of course, I'm worried about the free ion because it create the free radical injury, and it ultimately end up with the white matter injury. So if end product would be either your ventricular dilatation or hydrocephalus, but we need to see which one is end up with your therapeutic intervention. And why it is important? Because any ventricular dilation can pressurize the adjacent structure, particularly the parenchyma. It prevents their development, and it ultimately end up with the white matter injury and followed by poor neurodevelopment outcome. So it is necessary to monitor the post-hemorrhagic thing. So what is the way of ventricular dilatation? It is not necessary that each and every dilation is end up with the hydrocephalus, or either we can't call each dilation as a hydrocephalus. We need to know that what's the origin of the ventricular dilatation. Most of the time it is because of the raise in internal pressure, like post hemorrhagic one. There would be the more CSF production, less absorption. And second would be it might be due to the injury of the surrounding brain. So basically it is occupying the space. How will you know that one? Second thing, you need to know what's the normal variant of the lateral ventricle. In the term baby, you hardly see the ventricle. You can't see any third ventricle or lateral ventricle. Even in the preterm baby, most of the time you can see the asymmetry. That is also normal, and most of the left side is a bigger size. So how will you identify the origin? So this is your again the ventricular view, mid ventricular coronal view. This is your interhemispheric fissure. This is your corpus callosum. This is your cavum. This is your lateral ventricle, and that would be the thalamus over here. Okay. So when you see the dilatation, you need to see the lateral border of the lateral ventricle. If it is like concave, that means it is occupying space. So this is because of the periventricular injury or parenchymal injury. Okay. If there is a raise in internal pressure, your lateral border would be convex. Okay, so this is because of the raise in internal pressure. This is most of time post hemorrhagic one. You can see the resolving hemorrhage over here also. So once you see the convex, it is because of the raised internal pressure. Once you see the concave, that is because of the parenchymal injury. Now this is your term baby scan. You can see hardly you can see the lateral ventricle, more sulci and gyra, or this is your Sylvian sulcus. Okay, and this is your sagittal view, parasagittal view. You hardly see the any lateral ventricle. You can see the choroid plexus over here, which is limited over here. You can see there is your thalamus. This is your caudate nucleus. This is your caudothalamic group. So this is your term baby's head scan. And the preterm baby, commonly in extreme term, we can see unilateral dilatation of the lateral ventricle, although it is a normal, but will still need to follow the baby. Okay. So now what happened if there is a post-hemorrhagic ventricular dilation, or like we can call hydrocephalus? So it is common in the grade 3 and grade 4 because it is around 7 to 75%. In grade 2, it is around 12%. So how will you monitor the things? If I talk about the clinical findings, most of people are used to do the head circumference. And which are the other symptoms? The widening of the suture, AF is bulging, and no pulsation through the AF, sunset sign, apnea, vomiting, bradycardia. That's all are vague symptoms because it can happen with the other pathology also. So we have to monitor the head circumference. But what are the limitation of the head circumference? Once you get the head circumference rising, by that time already damage done in the brain because the skull is very compliant and there would be collection of the fluid in the lateral ventricle which pressurize the adjacent structure and it ultimately end up with the white matter. So we need to peak the collection of the fluid as early as possible, and it is possible with the ultrasound. Okay, so when we need to do the intervention that we discussed in the few slides, but what are the intervention we need? That is, one is a lumbar puncture. If maybe require multiple lumbar puncture, then we think about the reservoir and followed by shunt surgery. And what would be the outcome? Of course, grade 1 and grade 2, I am not worried at all. But grade 3 and grade 4, we have to worry, and it would be associated with the poor neurodevelopment outcome if it is not timely intervened. But grade 4, of course, even though you timely intervene, there would be possibility to have a poor neurodevelopment outcome. So this is your one example, grade 2 IVH, and when you monitor serially, you can see it resolve automatically. So no need to do anything. How will you do the ultrasound monitoring? So we have a 5 indices in front of you. One is a ventricular index, which is widely accepted, and there is a lots of research on that one, and people mostly use its parameter for the therapeutic intervention. The supplement indices are anterior horn width, third ventricle dilatation, thalamo-occipital distance, and RI of ACA or MCA. So how frequent we need to do the ultrasound? That is another question. So there is no any concrete guideline, but when you find the IVH in first week of the life, definitely need to follow. Sometimes need to do the daily. Once you see that there is a static grade 2 or grade 3 IVH, you can do the twice a weekly. And if there is no collection of the fluid or static VI, then you can do once a week or twice a week. What we should follow. So as I told you, the ventricular index is the most reliable index currently, and people are used to follow that one. And the normal limit would be mentioned in the Levin index. What would the excellence? We already discussed therapeutic lumbar puncture. If require more time, then we think about the reservoir and follow by some. So what is the ventricular index? So for that we need a coronal view, mostly foramen Munro. Okay, how does look over here? You can see over here there is a lateral ventricle over here. This is your foramen Munro, and this is your third ventricle. This is your inferior horn of the lateral ventricle. You need to measure the things from interhemisphere fissure or either Fox Severi. Both are same. and it travels from midline to the lateral most or lateral wall of the lateral ventricle. Once you measure that one, you can see this kind of parameter over here. The second important thing, limitation. As I told you, when there is a porencephaly, how can you see the lateral border of your lateral ventricle? It is already merged with the lateral ventricle. So in some time, we need to follow the unilateral measurement. Second thing, limitation is occipital expansor. So when there is a collection of the fluid start after 2 weeks, because the occipital horn is very complex, most of fluid are collected over there, and you can't get any difference in the VI, serial VI. Okay. Okay, so we measure the ventricular index, but when we need to follow, or how we can, know that does it normal, does it abnormal, should we do the lumbar puncture or not? So for that, we need to follow this Levin index. This is your graph over here. You can see there is a gestational age on your y-axis, and this is your y-axis, and this is your x-axis. So you can see the numbers over here. Okay, there's a two line over here. One is 97 centile and one is 97 plus 4 mm. Okay, so people are used either of that one. We are following the 97 plus 4 centile. Some of the European country, they are following the 97 centile. So if your VI is more than that one, that means baby need the intervention. So luckily I got this case on last Friday. So this baby is 37 weeker, day one. The antenatal diagnosis of the hydrocephalus, possibility aqueductal stenosis. We haven't know it is a post IVH or intermittent hemorrhage or not. Once baby delivered, baby was stable, and we did the head ultrasound within the 1 hour of life. And this is the picture at 1 hour of life. You can see the VI is very high, 23 and 19. But as I told you, we need to compare with the Levin index. So what we did in our unit, we put the number according to gestational age. So this is your 37 plus 1 weeker, am I right? So if you see the limit of 97 plus 4 mm1 is 17.1. So anything more than 17.1 of the VI, we need a therapeutic intervention. So it is already crossed over here. Am I right? But before doing anything, we did also CT scan, because we need to know that does it communicating or non-communicating. And luckily, we got the communicating hydrocephalus, and we did the therapeutic lumbar puncture. We removed the 10 ml per kg, means 30 ml of the CSF. Even though after doing a therapeutic intervention, the limit is still remain high, but it goes down. It is decreased like by 2 and other side of 1. So you can't do the frequent lumbar puncture, otherwise you will end up with the consequences. So you can earliest do the every 12 hours. So we follow the sequence we did every 12 hours. And today only we got ventricular index just below the threshold. So you need to follow that one. Which are the other index? This is your anterior horn width. Okay, so this is your, again, the lateral ventricle. How does it look on the image? So let's take this same image which we measure the VI. It is a diagonal width of the anterior horn. It is measured from both lateral ventricle. Okay, and you can see the number. Anything more than 6, it is very significant. Already it is a 16 and 17. What is the third ventricle dilatation? Again, the same picture, we measure the third ventricular dilatation. It is a 12.9. Anything more than 3 mm, again it is a very dangerous for the baby. Now, last indices is the thalamo-occipital distance. So how can you assess that one? So again, paracetatal, you can see that your patient say lateral ventricle. You need to.
Vishal, I think so. His internet has connection is gone. We'll just wait for some time.
Hello. Can you hear
Yes,
me?
Vishal. Now we
Sorry,
can hear
that
you,
that's
but the
when
net connection got
oh my
disconnected.
God. Okay,
So we couldn't
when
see,
it disconnected.
yeah, you were at basically you were at anterior horn diameter. You finished. We couldn't see the slides changing after your this thing, ventricular indexing. So you can start with the anterior horn diameter thing.
Okay. Okay, sir. Can you now see the slide?
No,
Oh, okay. Mm. Now,
nine.
hello.
No,
Oh, just give me 1 minute, sir. I think there is a poor network. I think suddenly. Just give me, sir, 1 minute, sir, please.
yes, now we are able to see. Hello, Vishal.
Hello, can you see, sir?
Yeah, now we can see.
Hello. Okay, sorry for interruption.
You start with the anterior horn.
Ventricular index, am I right?
Now
Yeah,
you
anterior
complete the
horn width.
ventricular index
Okay.
is fine. Anterior horn diameter.
Okay. 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 So this is your anterior horn width. Can you see now? Am I right? Should I continue?
No, your slides are still stuck at Thelmo hospital distance. They are not moving.
Now, sir.
No. Yeah, we are able to see, and the slides we are able to see is third ventricle diameter.
Hello.
Yes,
Hello.
we are able to see. We are able
Sorry,
to
I'm
see
really
your
sorry.
slide.
Now the connection would be secure now. Okay, so this is, did you see the, hello?
Yeah, your third ventricle slide is visible. Third ventricle dilatation.
Okay, now, yeah. So this is your anterior horn width. So how can you see same the foramen Munro view? You have to measure the diagonal width of anterior horn maximum width over here, like medial to lateral wall of the lateral ventricle, and you can see this parameter on the left hand side. That is number is 16 and 17. It is very high. So anything more than 6 mm, that would be the your red flag. If you want to calculate the third ventricular dilatation, again the same view, you can measure the most widest point of the third ventricle, and it is now you can see number is 12.9. Again the number is very high. The normal limit would be less than 3 mm. This is your last thing, thalamo-occipital distance. And again, you can use the parasagittal view. And if you see, this is your lateral ventricle over here. This is your old hemorrhage, and this is your choroid plexus. So be sure that you are measuring on the posterior wall of your thalamus from here to occipital horn of the lateral ventricle, and you will get this kind of number on your screen. It looks 35, but anything more than 26, it is abnormal. Okay, so if what are the red flag sign for the hydrocephalus when we need to therapeutic intervention? Your VI, if it is more than 97 plus 4 mm, if your anterior horn width is more than 6 mm, if your third ventricle dilation more than 3 mm, or thalamo-occipital distance more than 26 mm. So we need to think about your therapeutic intervention. Okay, you can see there is a green, yellows, and red zone. So based on your ultrasound, you need to put which zone you're fitted in your baby. If it is your 97th centile, if your weight is more than 97 centile, for example, and if there is any signs or absent of the clinical sign over here, then in this case you need to refer this baby to the NSU where the neurosurgical intervention can possible. And as I told you, few of you need to follow the 97th centile, and they start doing a lumbar puncture daily. And after, if it is not settled within a 2-3 lumbar puncture, they will think about the reservoir. In that case, you need to do the cranial ultrasound at least alternate day, and followed by, once it's stable, you need to do every once or twice a weekly until 34 weeks of the gestational age, corrected age. If it is your 97 plus 4 centile, like in our case, it is already crossed. Anterior horn is more than 10 mm. Thalamo-occipital distance is more than 25, or any of the clinical signs or symptoms, definitely baby is fitted for the therapeutic intervention. Initially lumbar puncture, and followed by we need to think about the neurosurgical intervention if it is not settled. Now last part is the resistive index, and so we did lots of session regarding the echo, and in that case you able to calculate the blood flow. So why we are not calculating, we could not calculating same thing in the cerebral for the brain. The two things we require to assess the blood flow, one is velocity and one is your diameter. The diameter of the all the cerebral artery is very small, so it is difficult to measure the exact diameter. Again, even though you calculate the velocity, if you select, like if velocity is very high, in that case your blood flow in the brain might be normal also. In same thing, if it is low velocity, still your blood flow would be normal in the brain. So that's why the resistive index is come into the picture. And what is the resistive index? Basically, it measures the resistance of the brain. So how will you calculate? It is your end systolic volume or peak systolic volume minus end diastolic volume divided by end systolic volume. Okay, so and this diastolic volume is mainly dependent on your resistance. It is inversely relation with the diastolic volume. If your resistance in the brain is high, you will get a high RI. Okay, so this is also depend on the PDA. If you have a hemodynamic PDA, HSPDA, you are not going to see the diastolic wave. Okay, it might be absent. It's difficult to calculate the RI in that case. But if there is a PDA is not there, and if it is a absent diastolic volume, that means your RI is very high. Somebody yesterday asked about the PI, pulsatile index. So it is a like almost same like a resistive index. Only thing, is the end systolic volume minus end diastolic volume divided by mean systolic volume. But there is a limited data for that one. So people are usually use the RI, which is very good parameter to assess the earliest intracranial pressure. The normal value would be 0.6 to 0.7. If it is more than 0.85, that is your raised ICP. If it is more than 1, that is your impaired perfusion. So how will you assess? You can do the mid sagittal view. You can see the anterior cerebral artery. This is your anterior cerebral artery, which is become straight in front of the genu. This is your corpus callosum. Over here, your straight. You can see the straight pathway. So in that case, you need to put the sample gate over here. Click the pulse wave Doppler. You can see the positive, velocity just above the baseline. And most of time now we can calculate easily in modern echo machine. You need to click the RI button, put the 2.1 is a peak systolic and 1 is end diastolic volume, and it automatically calculate the velocity, sorry, RI, that is your 0.8. Okay. So how can you assess the MCA? Why people are used to do the MCA? Because it is the largest artery in the brain and it is mostly straight. When you do the view through your coronal suture, this is your coronal suture. So you need to put the axial probe over here. Once you see the image over here, you can see that is a straightforward course of your middle cerebral artery. So basically, this is your internal carotid artery. Once it's separated from the internal carotid, it travels laterally over here. And once it reaches to the lateral sulcus, it supplies the outer and superior part of your whole hemisphere. So how does it look on the on the ultrasound? This is your MCA. You can see that is a straight course, and this is your ACO around over here. So you need to put the sample gate over here, and then once you put the sample gate like ACA, you can assess your RI. So this is our again the old baby which we discussed in the VI. I did the RI on admission, and you can see there is no any diastolic flow over here. So when I measure the RI, it is 1. That means there is already impairment of the perfusion. And once I did the lumbar puncture, you can see over here, the RI is drastically improved. So it convert into 0.6, and after the lumbar puncture, the resistance goes down and you can see the diastolic flow over here. Okay, so you can also monitor the RI before lumbar puncture and after the lumbar puncture. So till now in the hydrocephalus, we can measure the ventricular index through the foramen Munro view from midline to the lateral wall of the lateral ventricle. You can also measure the anterior horn width from diagonal, highest point between two ventricles, and third ventricle, the widest point of the third ventricle over here. So this is your coronal view hydrocephalus indices. And in sagittal view, parasagittal view, you can assess the thalamo-occipital length over here. So start from posterior part of the thalamus to the occipital horn of the lateral ventricle. Okay, and this is the last slide. This is your cerebellar hemorrhage actually. So when you do the mastoid view, you can see this kind of normal image over here. There's you can looks like a sulci and everyone. This is your cerebellum. This is your vermis, and this is another lobe over here. So this is your echogenic foci. You can see in the cerebellum over here. Okay, so that is your cerebellar hemorrhage. So once you get the grade 4 IVH, definitely you need to look for the cerebellar hemorrhage. So take home message would be that it is a very easy scan. When I take the POCUS session, most of time I will say each and every delegate that the lung ultrasound is the easiest ultrasound in the world, followed by the head ultrasound, which is again the easiest one, and followed by your difficult one, echo. Okay, there would be no radiation exposure if you do the frequent monitoring. It is very sensitive tool for the IVS screening, and also you can monitor the hydrocephalus with the various indices. Please try to use your supplement use basically if you in the Doppler specifically to rule out the cerebellar hemorrhage, or if you want to do the MCA RI, then definitely need to use the temporal view. Again, it is a less sensitive for the white matter injury, posterior fossa infarction, and HI. Thank you.
Thank you, Dr. Vishal. It was invariably a very nice session. Very precisely and in detail, you have discussed IVH and hydrocephalus. If anybody has got any questions, they can write down in the chat box. There is one question: how to distinguish between old and new IVH?
So old IVH, there would be, you can see the ecolucent sea in between that one, like in the ecogenic foci. That is your old IVH. Sometimes it is a flying in the floating in the CSF. That is your old IVH. Generally, you can't see same thing in the new IVH.
So the fresh blood will be hyper